So here is the paper that actually shows that A1C can change if the blood glucose is normalized. So I'm showing you a week of A1Cs. So these are women who are followed every single week in county clinic with a point-of-care A1C. And as you can see, the mean difference in slope is a 0.5 percentage point per week if indeed the women are normalizing their blood glucose. What's marvelous about this is it's a behavioral change because the women actually can see their own A1C. They knew what their last week's A1C was. So if they look at this week's A1C and see it's improving from last week, they feel very excited, and I barely have to do anything because they know they're doing a good job. But the truth is you can normalize an A1C within 4 weeks of initiating normal glycemia. The cost savings to Santa Barbara County. Now, we're a public health service, and so you understand the state of California is having trouble with its economic welfare of our undocumented patients. But the cost savings to the county is over $2.5 million a year because these babies are normal, the mothers can have a normal vaginal delivery, and the babies don't end up in an intensive care unit. So now we have to talk about how do you diagnose gestational diabetes. And this was the biggest controversy and debate in diabetes and pregnancy over the last 50 years. So I show you 4 different ways of diagnosing gestational diabetes, and it got to be ridiculous because the drink, the quantity of the drink, the number of time points, the way you diagnose it, the cutoff was absolutely ridiculous. So we're talking about 1973 to the year 2000, nothing really changed. It was your choice of doing a 1-step, a 2-step, and what criteria you chose. Then along came the hyperglycemia and adverse outcome in pregnancy trial that your tax dollar paid for. And this trial was published in the New England Journal of Medicine and recruited over 25,000 women around the world to have a 1-step procedure with a 75-gram oral glucose tolerance test and looking at the fasting 1 and 2-hour time point. Now, this was only a 1-step procedure, and the answer is if you look at one figure, which is worth 1,000 words, it was published in the New England Journal of Medicine, you can see that any elevation of either the fasting, the 1, or the 2-hour is associated with an increased risk of macrosomia, birth weight, an indication for cesarean section, and also an increased risk that the baby will have hyperinsulinemia. And as we mentioned at the beginning of the talk, hyperinsulinemia is what causes obesity. So the problem is the obstetricians were not very happy about the changing of the definition. And the reason is that the prevalence of the diagnosis of GDM goes from about 8.3% up to a prevalence rate of close to 18%. So it doubles the number of women we have to take care of. But my answer to the obstetricians is it's easier to treat 2 people than it is to treat 1 person, and really does not significantly increase the cost of care in order to treat diet, exercise, and teaching women how to take good care of themselves. But the American College of OBGYN still recommends the 2-step because they're concerned of the burden of care that we'd have 18% of our population with a diagnosis of gestational diabetes. However, there is a subpopulation of women who have undiagnosed type 2 diabetes. And the truth is they are different and they need care immediately. There are clinical characteristics that will help you identify the woman who has undiagnosed gestational diabetes. Now, this is my waiting room out at County Clinic. And once I teach you how to recognize clinically undiagnosed type 2 diabetes, you'd be able to pick out those women you'd say instantaneously needed care and had no time to wait for diet and exercise and lifestyle change. You'd immediately want to give them treatment. So the paper that I published together with a wonderful researcher from Japan, Professor Omori, we identified clinical characteristics. But actually, the great painter Botero knew these characteristics. He knew these women were overweight, unfit, but also had acanthosis nigricans. Now, Botero loved these black lines that surrounded the neck and caused women to be slightly hairy. Acanthosis nigricans is defined by Wikipedia to be a brown to black, poorly defined, velvety hyperpigmentation of the skin. It's usually present in the posterior and lateral folds of the neck, the axilla, groin, umbilicus, and other areas. The most common cause is diabetes. It's diabetes, diabetes, diabetes. There are some cases of cancer that may cause acanthosis nigricans, but even polycystic ovarian syndrome, which is a type of insulin resistance, causes acanthosis nigricans. So we can use blackened skin to help us identify those women at risk for undiagnosed type 2 diabetes. This is Botero's statue in the middle of Manhattan, and he has a woman lifting up her arm so she can show off her armpit that she has acanthosis nigricans in her armpit. And you notice that she's slightly rotund, but if you walk around in the back of the slide of the statue, you will see that it's easier to make the diagnosis of acanthosis nigricans by the lines on the back of the neck, which, believe me, is a lot nicer to ask the woman to lift up her hair so you can see her neck than ask her to show her armpit. So in the back of Botero's statue, this woman is lifting up her hair so that the world can see that she has blackness of the skin in the back of her hair. Actually, if you look carefully, you can see me looking at the statue, looking at her, looking at the cameraman trying to take the picture. But you know, women know that they've had acanthosis nigricans forever. So you just have to ask a simple question. Did your mother complain that your neck was dirty? That's all you have to ask. And the answer is, this particular woman got the diagnosis of gestational diabetes. But looking at the back of her neck, you could see she had severe acanthosis nigricans. She also had skin tags, which shows long-standing hyperinsulinemia. Her blood sugars were greater than 300. And I said to her, you know, the truth is, even though we're making the diagnosis now of gestational diabetes, the truth is you have undiagnosed type 2 diabetes. So let's look at the A1C at the time of diagnosis. I want you to see that there are two populations. The population with an A1C less than 5.3% and a population greater than 5.3%. And the BMI, or the index of how big these women are, is related to the A1C. So if I blow up the section right around 5 to 6% A1C, you can see that 5.3% will tell the difference between those women who can be easily controlled with diet and exercise, and they're the leaner women, and those with an elevated A1C who are more overweight, unfit, and really do need care for their diabetes immediately. It is true if they have undiagnosed type 2 diabetes, they would also have an elevated systolic blood pressure. An A1C of 5.3% also differentiates the difference in systolic blood pressure. A higher blood pressure is also associated with increased complications during pregnancy. So it's time to turn the tide to diagnose type 2 diabetes during pregnancy differently. It's an elevated glucose on the glucose tolerance test, an elevated blood pressure, an elevated A1C, it's an elevated BMI, and it's any evidence of acanthosis nigricans. So what about the diet? Well, the truth is, if the postprandial blood sugar is the major villain in causing macrosomia, then indeed you would want to minimize any increase in carbohydrate to elevate the postprandial blood sugar. So if you look at the caloric requirement by age, you'll see the pink dots represent the little girls, and the blue dots represent the little boys. And what's not fair is that a little girl can never eat as much as a little boy. But now look to see when she grows up and she is either pregnant or lactating, what's not fair is that she can never eat as much as an adult male. But if you take a linear regression line through all the pink points on the graph, it crosses the x-axis when a woman is not allowed to eat anything. So we talk about the ideal diet. It really is allowing the women to realize they have to minimize their meal plan in order to keep their postprandial blood sugar normal. The treatment must target the postprandial blood sugar. It's the only way that we will prevent macrosomia. So you ask the question, so what is the percent of carbohydrate that we can allow these women to eat without causing postprandial hyperglycemia? The answer is less than 33% of the meal plan, which essentially is anything that is considered a carbohydrate is dangerous, so anything white. But what we end up doing is the obligatory carbohydrates in vegetables and the conversion of some amino acids into glucose is the whole way we deliver carbohydrate to women. We absolutely deplete their carbohydrate content of their meal plan, and it helps improve their postprandial blood sugar. So what is the insulin requirement that we use? Now, I have to tell you, because I feel very strongly that the oral agents cross the placenta and are not helpful in treating the postprandial blood sugar, we insulinize as soon as we meet the women, and we use an algorithm that allows us to make a constant to multiply a constant times the woman's weight in kilograms depending on her gestational week. Most women receive the diagnosis of gestational diabetes between 24 and 28 weeks gestation. So the constant usually is 0.8 to 0.85 times the weight in kilos, which is the total daily insulin requirement. We divide the total daily insulin requirement into half being basal and half being bolus. And the bolus is surrounding each and every meal plan. So we give insulin to provide the basal needs and insulin to require the bolus needs. So we divide big I in half. 50% is basal, 50% is bolus. Now, it was wonderful when human insulin came along because, of course, it doesn't cause an antibody response, and therefore it's not as worrisome that it would be carried to the fetus and be causing hyperinsulinemia. But human insulin is very slow in action. The orange dots show you how long it takes for human insulin to get into the bloodstream, which isn't fair because it would mean women would have to get up at 4 o'clock in the morning in order to eat breakfast by 7 o'clock in the morning. If we had a monomeric insulin or an insulin analog that had an immediate onset and a peak at a 1-hour time point, it would be perfect for us. So we did the original clinical trial showing the safety and efficacy of insulin lispro. And the reason it's called insulin lispro is because lysine and proline were switched in order in the V28, V29 position, which allowed the insulin to be absorbed faster. The second insulin to be tested to be shown the safety and efficacy during pregnancy was insulin aspart. And the reason it's called insulin aspart is because aspart is substituted for proline in the B28 position. And we've done a lot of studies, but also the Europeans have done a lot of studies showing that aspart really does treat the postprandial blood sugar and really doesn't cause, with a long action of human insulin, late onset hypoglycemia, which makes women hungry and eat between meals. So this slide also shows you, in addition, the C-peptide response is lower at the 2-hour time point using insulin aspart, which is very nice because the insulin works now for the food and is gone between the meals, so it doesn't force feed the women to feel hungry and eat more than they should.